So what are important prostate cancer facts? This information is crucial because much of the messaging out there in the prostate cancer arena is false and will only lead you to health dangers. Welcome to HEALTHdrum. I'm Dr. Bert Vorsterman, a urological surgeon and former researcher, and this channel is all about sorting out medical fact from medical fiction. By the way, HEALTHdrum provides material for educational and informational purposes only and is not a substitute for professional medical advice. The links to the disclaimer and the material in this video are in the description below. And if you like to get fact-based healthcare information, please hit the subscribe button for me. Okay, so let's get into it and start sorting out fact from fiction. So the prostate cancer arena seems very alarming, convincing, and logical. But in this journey, you'll discover that it is unreliable, unsafe, and unproven. So what's the reality about most prostate cancers? Here are some key facts. Most prostate cancers grow very sluggishly, taking 40 years or more from the time of mutation for the growth to reach about 1 centimeter or half an inch in size. Most men die with their prostate cancer and not from it. The Gleason 6 is a pseudocancer or false cancer, and some 10 to 15% of prostate cancers are high grade and potentially dangerous. Clearly, prostate cancer is a spectrum of diseases and not all cancers are the same. Also important is to know that despite the prostate cancer industry claiming that urinary and sexual symptoms are early warning signs of prostate cancer, this is pure deception. These are not early warning signs of prostate cancer, but simply signs of aging. So the Gleason 6 is still labeled as cancer, but it fails to behave as cancer, as you will see. The Gleason 6 is a false cancer. The grade 3 growth pattern was originally thought to be a low-risk cancer based purely on subtle, low-power microscopic appearances. As well, there were some other irregularities such as partial loss of the basal cell layer, some minor molecular changes, and some ability for perineural invasion that were used to support the claims that the Gleason 6 was a low-risk cancer. However, all of these changes are also seen in benign conditions as well. Also, there's no credible evidence that grade 3 cells can transform into a higher grade over time. And despite decades of scrutiny, there remains no verifiable evidence that anyone has died from the Gleason 6 disease alone. So what are the forces that continue to push the false messaging about the Gleason 6? So why does the Gleason 6 deception continue? Several factors perpetuate the false cancer labeling. The urology community exploits doubt about the Gleason 6 by maintaining the cancer label to enable over-treatment of the disease. Cancer lobby groups and prostate cancer awareness organizations can continue to exploit the false cancer label and recycle misinformation to secure funding. As well, prostate cancer statistics are greater than what they should be for the purpose of fear-based marketing. And life insurance companies can terminate or deny policies for those diagnosed with the Gleason 6 disease. In fact, both institutional and financial incentives are a major problem in the healthcare arena. So let's now examine the criteria that are necessary for these prostate cancer screening tests to be useful. So these are some of the very well-known criteria that must be met for a screening test to be useful. Criteria such as requiring a high sensitivity and specificity, that the test is safe and acceptable to patients, that it's readily available and cost-effective, detects disease early, and allows complication-free treatment with scientific evidence for life extension. So let's see how all of this pans out in the prostate cancer arena. So let's see if the prostate exam or digital rectal exam meets the criteria for being a useful screening test. So the prostate exam can be conducted with the patient bent over the examining table or lying on one side. The practitioner uses a gloved and lubricated finger to enter the rectum and examine the prostate. It takes only a moment, but can be quite uncomfortable in those with an anal fissure, anal stenosis, or hemorrhoids. The prostate exam is quite unreliable as it's based on a judgment by the practitioner, and different doctors will have different impressions about what they're feeling. As well, nodules or irregularities in the prostate need to be at least about 1 centimeter in size before being routinely detectable, and deeper nodules need to be bigger in order to be detected. On the other hand, most prostate nodules are benign or non-cancerous, and there's no evidence that this test is life-saving. In fact, the prostate exam is a medieval junk test, highly unreliable and unjustifiable. Even more illogical are the 6-monthly prostate checks that many doctors recommend. So the other prostate cancer screening test commonly recommended is the PSA test. Let's see how reliable that test is. The PSA test is a highly unreliable test and has a false positive rate of about 78%. The test cannot distinguish between aggressive and non-aggressive cancers. Its specific label is pure intellectual dishonesty, as there is nothing specific about it. It's not specific for prostate cancer or for the prostate. The so-called normal range of 0 to 4 being normal is pure fiction. As well, big prostates generate big PSAs, and most of the cancers detected are because the PSA was elevated by the prostate enlargement and not the indolent cancer detected. By any standard, the PSA screening test is a gigantic screening test failure. And there are even more concerns about the reliability of the PSA test. PSAs fluctuate during the day and between labs. PSAs are easily raised or lowered by various benign processes. They are lowered by various drugs such as prostate, cholesterol, and blood pressure medications. And when you come off these medications, your PSA will rise. The PSA is easily elevated by urinary and prostate infections, prostate checks, catheters, and so on. A low PSA doesn't mean you have no cancer, and a high PSA doesn't mean you have cancer. On the other hand, high-grade prostate cancers may produce little or no PSA. And because the PSA test is so highly unreliable, the FDA approval to use the test for prostate cancer screening was a gigantic misstep. So the prostate exam and the PSA test are highly unreliable, but do these tests save significant numbers of lives? So there's no scientific evidence that the prostate exam saves significant numbers of lives. As well, urologists' own studies have determined that PSA testing fails to save significant numbers of lives. In fact, there's no other biomarker available that has been proven to save significant numbers of lives. Yet, the prostate cancer industry and prostate cancer awareness organizations continue to exploit the fear of cancer by having men undergo these highly unreliable screening tests for which there is no evidence that they save significant numbers of lives. So despite the PSA test and prostate exam being highly unreliable and failing to save significant numbers of lives, any abnormalities detected with these tests will have you pushed into having further risky tests. So the non-contrast MRI of the prostate is usually recommended for any abnormality found on the prostate exam or the PSA screening tests. However, the equipment requires good software, great technique, and an expert radiologist. With this background, the non-contrast MRI is able to detect the size and location of any tumors with a high degree of reliability. And it's able to determine whether the tumor is high-grade and aggressive or not. But growths need to be at least 5 millimeters in size or larger in order to be detected. Otherwise, they will be missed. Also, MRIs can deliver false positives because of inflammation, nodular BPH, radiation or hormonal changes, and post-biopsy hemorrhaging. And the target threshold for a growth in order to be reliably biopsied with a needle biopsy is about 5 to 7 millimeters in size. If the lesions are smaller, they are likely to be missed on needle biopsy. So let's talk about the reliability of prostate needle biopsies. Unfortunately, most of them are still done in the doctor's office, but the most reliable way of doing them is targeting the lesion during an MRI study. So the prostate needle biopsy is associated with significant risks that include septic shock, bleeding, urinary retention, and urinary tract infection, and so on. The test, whether transperineal or transrectal, is also associated with a huge sampling error. Usually about 12 needle cores are taken, and when the volume of the 12 cores is measured against the volume of the prostate, only about 0.1% of the prostate is being sampled with the needle biopsy. This leaves the physician clueless about what's going on in the 99.9% rest of the prostate. In other words, your diagnosis and medical management is based on a 0.1% sampling of the prostate. As well, 80 to 90% of all prostate cancers are multifocal, meaning that there are 2 or more areas of cancer. The reason for this is that prostate tissue is impacted by field effects, a condition where prostate tissue has been sensitized to develop a cancer at some point in the future. So, because most prostate cancers are multifocal and the biopsy samples only about 0.1% of the prostate, it's clear that most so-called cancer progression and upgrading discovered on a subsequent biopsy is simply due to the fact that these cancers were present but missed at the previous biopsy. So these biopsies now go for pathological diagnosis. How reliable is getting a prostate cancer diagnosis from the pathologist? So when it comes to your prostate biopsy report, the Gleason grading and scoring system for prostate cancer is complex. The 2 most common patterns of growth seen under the low-power microscopy are graded from 1 to 5, with 5 being the most aggressive. These 2 grades are then combined for a Gleason score. However, because grading requires a judgment on the part of the pathologist, observer error is not uncommon. As well, grade misclassifications and disagreements between pathologists are not uncommon. This means that your biopsy may be underread and you actually have a higher grade of cancer, or overread and you actually may have a lower grade of cancer. That's why it's important to get a second opinion from a prostate cancer pathologist. So when you see the urologist concerning your biopsy report and the diagnosis of cancer, they invariably start talking about treatment options. So what is that about? So these are the treatment options for localized prostate cancer. You'll hear about surgery, whether open or robotic assisted. You'll hear about external beam radiation with or without androgen deprivation therapy or testosterone suppression. Then there's brachytherapy or radioactive seeds, proton beam, and focal therapy options using either high-intensity focused ultrasound or HIFU, cryoablation or freezing, laser, or photodynamic therapy /PDT. But after this information bombardment about prostate cancer treatment options, your physician will likely want to do some tests to make sure that the prostate cancer is localized. So what's the story here? So these are the tests commonly done for someone that has what's believed to be a localized prostate cancer. A whole body MRI to see if there's any bony spread, a PSA PET or CT scan to detect soft tissue spread. However, the problem with all of these tests is that they can have false positives from inflammation, small cancers that can't be detected, technical issues, observer error, and so on. Then there's also false negatives because the cancers are too small to be detected, and not all prostate cancer cells produce PSA protein, and so on. as well, especially for high-grade prostate cancers. They may already be disseminated into the bone marrow. And these can only be detected by bone marrow aspiration studies and sophisticated staining techniques. The problem with these disseminated cancer cells is that they may be dormant in the bone marrow for decades before some activate and spread after a semblance of cure. So your cancer seems localized and you go back to the physician regarding treatment options, but because they know that there are so many complications associated with their treatments, first they want to have you undergo some programs for managing patient expectations. So physicians are well aware of the many complications associated with the so-called standard of care treatments for prostate cancer, and they will go over these various treatment options and figure out your patient preferences and risk tolerances. Next, they'll get you to sign a very detailed informed consent explaining what they've gone over, all of the upsides and downsides. They'll also provide some preoperative counseling about what sort of complications are possible, and they'll have you undergo some postoperative rehabilitation programs, especially for likely limp and leaking complications. So surgery is often recommended, but was that procedure ever scientifically proven to be safe and effective? So this is how open surgery for prostate cancer entered the treatment landscape. It began with a belief that it should work, and then wild claims about how perineal surgery was associated with early diagnosis and radical cure. Both of these statements were a lie, as well as the claim about satisfactory functional results, because 2 patients died and the others were left leaking urine. But despite these terrible results, prostate cancer surgery went from a belief that it should work to accepted practice, to standard practice, and then on to standard of care without any scientific evidence for safety or benefits. What about robotic-assisted prostate cancer surgery? Was it ever scientifically tested for safety and benefits? So the robotic device went from the battlefield to gallbladder. A low-level study was done in Mexico comparing laparoscopic gallbladder surgery to robotic-assisted gallbladder surgery, because there were less rigorous regulations in Mexico compared to the US. Subsequently, the FDA approved robotic-assisted gallbladder surgery, although there were no clear benefits for this approach. When the device makers realized that there was no market for robotic gallbladder surgery, they took the device to urologists. They liked it and in no time had robotic-assisted prostate cancer surgery FDA approved through the underhanded 510(k) maneuver, a process that successfully bypassed any scientific testing for safety or benefits of robotic-assisted prostatectomy. So just like open prostate cancer surgery was never scientifically proven for safety and benefits, the robotic-assisted prostatectomy was never scientifically tested for safety and benefits. So because open radical prostate cancer surgery and robotic-assisted prostatectomy were never scientifically tested for safety and benefits, what sort of complications can we expect from these procedures? So it's not surprising that physicians have patients go through programs to manage expectations, because all of the treatments for prostate cancer are associated with a significant incidence of life-altering complications. Especially alarming is open and robotic surgery, which are associated with a high rate of residual cancer or positive margins in some 11 to 48% of patients. As well, all treatment options are associated with a high rate of rising PSA or biochemical recurrence in some 20 to 50% of patients within 10 years of treatment. Urinary and bladder complications are common, and sexual and penile complications are also very common. This is not surprising when the prostate cancer treatments went from beliefs to accepted practice to standard of care without any scientific testing for safety and benefits. So with this background of unreliability and health dangers associated with prostate cancer treatments, do these treatments save significant numbers of lives? So what's the bottom line with prostate cancer treatments? Urologists' own studies have shown that at about 20 years, those that had no treatment had similar survival rates to those that had radical treatments, but those that had no treatment did not suffer any of the complications commonly associated with radical treatments. Additionally, there's no irrefutable and reproducible evidence that radiation or focal therapy options save significant numbers of lives. And the lack of benefits for prostate cancer treatments make a mockery of the guidelines for localized prostate cancer, informed consent, standard of care, prostate cancer awareness campaigns, and so on and so on. Remember, the links to the articles supporting the many warnings in this video are in the description below. So let's recap. In this video, what are important prostate cancer facts? You learned that prostate cancer screening fails to save significant numbers of lives. PSA testing is highly unreliable and fails to save significant numbers of lives. Treatments fail to provide curative benefits. Tests and treatments are associated with many health dangers, and we need new tests and treatments that actually save lives. Sadly, prostate cancer awareness programs only exploit the fear-based cancer label and push men towards health dangers by recycling misinformation. The reason we're in this prostate cancer public health disaster is because physicians have failed to ask one of the most basic of medical questions, and that is, where are the irrefutable and reproducible data supporting our recommendations? To learn more about routine medical conditions, self-care, and digital health, check out these other videos, and if you like them, please share them with your friends.